So, on behalf of the Australian Primary Healthcare Research Institute, I'd like to welcome you all this afternoon to Associate Professor Josée Lavoie's talk, and you can see the title above. The Australian Primary Healthcare Research Institute is a Commonwealth initiative funded through the Primary Healthcare Research Evaluation and Development Strategy. And part of the research funding every year is made available to bring international visiting fellows to Australia. The International Visiting Fellows Program allows Australia's primary healthcare sector to benefit from the expertise of internationally acclaimed academics. The program aims to contribute to the knowledge base and research capacity relevant to APHCRI's strategic plan and, more importantly, to the national reform agenda. It also aims to facilitate establishment of new research collaborations throughout Australia. Associate Professor Lavoie is based at the University of Northern British Columbia in Canada. Her program of research is focused on access to primary health care in rural and remote environments and for populations living in marginalised circumstances. The research is placed at the interface between Indigenous health policy, financing and primary health care provision. While in Australia, she will be hosted by Professor Alex Brown from the South Australian Health and Medical Research Institute, and Professor Alex Brown has funding through APHCRI for a Centre of Research Excellence. She will work with she is working with that Centre of Research Excellence, and she's also going to work with other Centres of Research Excellence that we have funded and other key researchers to develop and strengthen partnerships related to improving access to primary health care for rural, remote and Indigenous communities. And as you may hear through this talk, or I'm not sure whether you will or you won't, but Josée is not new to Australia. She had time in Australia, in Central Australia, when she was completing her PhD. So I'd like you all to join me in welcoming Associate Professor Lavoie to this evening. Thank you.
So thank you very much for taking the time to come here and hear this talk. This was a very generous and kind introduction, so I'll try to live up to it. Welcome. So as Rebecca explained, my interest is working in partnership with the community control sector, among other organizations, working with the delivery of effective primary health care in rural, remote, and Indigenous community. And I've done some work here in Australia, and I continue to come back. I've been coming back for about 10 years, although my first time was in 1992, where I took a four-way drive from Cairns to Cape York. So I'm used to remote, and I'm attracted to remote for some reasons. But also worked in New Zealand, and I have worked recently in Norway with Sami in the northern part of Norway, looking at access to primary health care and the complexity of delivering in complex environments. I'll be talking about the First Nation managed healthcare organization and the system that we've rolled, but there's a fair bit of analogy that we can draw, and there's lessons that actually I've been drawing from Australia to inform my work in Canada, and there's a fair bit that also translate in terms of our experience from Canada into Australia. So I'll be trying to draw those analogies for you. This is basically the outline of my presentation. What I want to explore with you today is why we have more Indigenous managed health services than Australia, and it's not, we have more than you. But it is a context, and I want to speak in terms of context and history to explain why we are where we are and why things are slightly different, and we'll tease out differences from there. I want to talk about the models that we have that are in place. I want to talk about how it works, and I'll tell you how we know it works as well, so speaking about evidence-based conclusions or research-informed evidence. I want to talk about what works well, but also about what is not working so well, and we're still chipping out and trying to make the system work better. So what we have is a different story, a different history. This is North America circa, sorry, the date got erased, but it's 1750. And if you compare the map here, that story, to your story, you'll see right away the differences. our colonial experience becomes in 1492 with Columbus, who thought he was in India. And this is how we get the term Indian. And it's born out of colonial confusion and remains imprinted into our policies and our language until today for some strange reasons. But following Columbus came, the Spaniards. So you have Spain in the south, in orange. And they're present, although frankly, you know, this side, the west side, we found some evidence that the Spaniards were in British Columbia. Some communities have, you know, the helmet that they had, that they found that in the woods. And so the Spaniards were actually all the way up. France, the presence of the French is in blue. So France was very present in 1750. And then you have the British, and their presence was much more limited. And so the story that I want to tell today begins with in 1749, when the British invade a fort that was held by the French. And then in 1759, the British take over what is now Quebec City. And this is the turn where what was a country colonized by French becomes a country colonized by the British. And if you look at the map, you would think that, well, the British did not have a very strong hold. At that time, the American colonies are also talking about independence. And so the context for us, where I start the story, is that the British have just arrived and they are nervous. And so what we have in 1763 is this document. This, if you're going to retain anything about the difference between Australia and Canada, this is what you should remember. This is the backbone of every court case still today. It is the backbone of a recent ruling by the Supreme Court of Canada in terms of federal obligation towards Indigenous people. It's the reason why we have a provision in the Canadian Constitution that Indigenous people have the right to self-government since 1982. And it's the Royal Proclamation of 1763. The British are nervous, so they do declare that they have taken over from the French. So my people, from the French minority, are conquered. We are a conquered people. And we're told how the British Crown will relate to us as a people and what our rights are. But it does state that Indigenous people are not conquered, that they retain a title or sovereignty over their ancestral territory, that any encroachment must be negotiated, must be settled by treaty, and compensated. So the reason why we have treaty, the reason why we're still signing treaties today with First Nations, is not because we're nicer people, it's not because we're more enlightened, it's because the court, the Supreme Court of Canada, tell us that we have to. And that is and will remain a major difference with Australia. So what we have, a confederation, we become an independent country from England, although we still recognize the Queen as our Queen, in 1867, and then comes the treaty process. And the treaty process is, if you think in terms of a country that is huge, a lot of it is not surveyed. So we don't know where things are. First Nations know where they are, but you know, it's not mapped. And we don't have a sustainable economy, because the French and then the British have been extracting resources and sending that to the homeland, and we've not set up a sustainable economy. And where we're going with that is an agrarian economy. We need to get farming going. And so to get farming, you need land, and if First Nation have the land, then we need treaties. From the First Nation perspective, the treaties that are signed, and they're signed from 1876 to about 1910, 1914 is I think the last signature. And they are signed in the context of the epidemics. They are signed in the context of First Nation having been decimated by measles, chickenpox, smallpox. Some of those epidemics would take 50 to 80% of the community at any one time. And First Nation know that the settlers are coming. They know that they're going to lose the land one way or the other. And the Royal Proclamation is a great document, but it does not define what sovereignty and title means. It does not give specifics. So the treaty process in Canada, if you read the treaties, they tell you how many ox the community is going to get, how many acres of land, 128 acres for a family of 4 will be the size of the reserve at the time of the signature. It tells you they're going to get $5 every year as a treaty settlement. Every individual will get $5. It doesn't talk about indexation. So at the time what treaties were signed, that was you could buy a cow with $5, and now you can't buy 2 liters of milk. So indexation would have been a good idea, but it was not negotiated. And it set up also something that we have that is unique, that does not exist here, Chief and Council. Chief and Council is in the Indian Act. The first Indian Act was adopted in 1876. It's a form of governance that is based on a democratic process. It is imposed to communities in 1876 and displace and replace and sidestep local forms of governance. Communities that were matriarchal, for example, Chief and Council were men, because that's the consciousness of the colonial power. It's sometimes, today we see traditional governance living side by side with Chief and Council. Sometimes there's tension, sometimes Chief and Council is the only form of governance that exists. It depends on the community. But the importance of that is in every single community now, 609, there is a form of local governance that is recognized by an act of parliament, and that is where the discussion began between Canada and First Nation always. And our peak bodies, because we have them, are multi-sectorial, and they are from elected officials from those 609 communities from the leadership. And we have a national peak body, the Assembly of First Nation, that is also sort of a national iteration of the Chief and Council model. So we do have a form of Indigenous governance, and it has existed since 1876. Not a perfect thing, because it displays traditional forms of governance, but a very useful tool in terms of Canada having conversation with First Nations, in terms of ideas of self-government, ideas of policies and program rollout, and so on and so forth. So the Constitution in 1876 establishes Indian Affairs as being a federal jurisdiction. And the quote, it's not because we're nice, and it's not because it was a good idea, and so on and so forth. The quote from John N. Macdonald, the very first prime minister, is essentially, they'll be too expensive to fight, and humanity won't tolerate that we let them starve. So we have to do something. So the federal government will take over that responsibility. And the responsibility is very much, we need the land, we need treaties. And that's the mindset of the time. Healthcare is established as a provincial jurisdiction. That begins a debate that is still existing today as to who's responsible for what. And we've not sorted that out. But the federal government has assumed responsibility for First Nation health services on reserve. And so here you have the Office of Aboriginal Torres Strait Islanders Health, which is OATSI. At home, and that gets established in 1995. At home, we have the First Nation in Inuit Health Branch of Canada. It has had different names, but that authority, that responsibility, which is federal, is established in 1945. So we have 50 years of experience in sort of community control sector, the idea of delivering services to First Nation at a federal level. And so that brings a different context, that brings different experiment, different ideas that we've experimented with over time. The federal government begins to provide services on reserve in the 20s out of compassion, is what they would say. As of 1945, there really becomes a rolling out, systematic rollout of facilities in every communities. So it's federally funded and federally delivered. As of 1945, by the 60s, basically there's a clinic in every single community, unless it's a reserve that is within an urban center. There's an urban reserve in Vancouver, there's urban reserves in Calgary, and those, the expectation is community members will go to a provincial point of care. So I told you we have treaties. We don't have a treaty, we have treaties. And the treaties are more sort of pragmatic list of what it means, so how much land the community will get and so on and so forth. who gets an ox and who doesn't. There's different provision in different treaties. So Treaty 5, for example, has a provision, a tax exemption, so income tax exemption for First Nation that were signatory. Treaty 6 is the only one with a provision of health services. But these days, the treaties get basically amalgamated and treated as sort of a series of rules that apply to all First Nation for just pragmatic reasons. Treaty 6 has what we call the medicine chest clause, or what is called the medicine chest clause, and it's written in 1876. And I'll leave it to your imagination what may be contained in a first aid kit at the house of an Indian agent in 1876. But that is the backbone of First Nations perception that there is a treaty right to health, that the position that the federal government denies. And it denies it because of the text that's underlined. So this is the way the clause actually read from the treaty, that a medicine chest shall be kept at the house of the Indian agent for the use of benefit of the Indian at the direction of such agent, that in the event of the Indians being overtaken by pestilence or great famine, the Queen, being satisfied and certified by an Indian agent that something is actually going on, something needs to be done, will grant the Indian assistance based on what the Indian agent is saying is needed. We don't have Indian agent anymore. They were basically federally funded administrators. They were one for each reserve that issued permit allowing First Nation to leave the reserve, to cut a tree, to get health care for their children. And without that permission, think about the pink slip when you were in kindy, right? Trying to get out to go to the washroom. That's what I'm talking about, Ward of the States. This day we don't have Indian agent anymore. We haven't had, thank God, for them since the 1960s. But what we have is the Minister of Indian Affairs, the Minister of Health. So the way the Crown has read in the latest court challenge has read this particular article, provision of the treaty is to say, well, the Indian agent is really now the minister. So if things are to be decided by the minister at the direction of the minister, is really healthcare, access to healthcare is really a matter of policy. It is not a treaty right. The last court case was in 1966. Since then, we've had jurisprudence that established that a literal interpretation of the treaty is actually not appropriate, that the treaty should be interpreted in the spirit of the intent they were understood by the First Nation who signed the treaties. And so if there was a court case, and there will be one within the next 5 years, we're pretty sure, because there's discussions of it, the likelihood is that this would be interpreted in a much broader context. But, you know, your crystal ball, my crystal ball. So what we have is now we're coming to the 1970s, so every community has their own clinic, and they're staffed by federal employee. It's a nurse-centric system, it's not a GP-centric system. Our GPs are paid by the province, they're not paid by the federal government. And so it really is a nurse and community staff, and the nurse may be working with an expanded scope of practice to provide primary care, so the nurse practitioner model that you may be familiar with. Community control begins in the 1970s. In 74, 2 new positions are being created by the federal government to support nurses that are usually non-Indigenous, that are non-Indigenous at the time. The community health representative, which is basically the Aboriginal health worker, that kind of a role, a paramedical role to support and assist and translate and so on. And addiction workers to deal with alcohol addiction mostly. And these are the first instances where Chief and Council is actually contracted to hire these people and manage those roles. But the rest of the team remains funded and delivered by the federal government, and these are nurses. 1982, the Constitution changed, and we become, and included in there is Section 35, which provides Aboriginal people, guarantees Aboriginal people's right to self-government, not self-determination, but self-government. And so thereafter, new policies build on that to try to transfer program to Indigenous control to Chief and Council so that they can be managed by Chief and Council. So we now have 3 different models for health services. So all those clinics become available for First Nation to self-manage. And the color there match the map that's coming next to it in the next slide. So remember the colors. The first model is it's really the green model. I'll call them by the color, it's easier. The green model is basically just a collection of contracts. They're 1-year contracts, and it's a program that the federal government developed, and basically the community gets to manage and deliver on behalf of the federal government. So that's the least amount of community control you can have. And the nurses usually remain federally employed under this model. The pink model, we called it the integrated model. It's a flexible contract block funded for 3 to 5 years. So a community may decide that they want to go under this model. They can take on that model anytime. It's been in place since 1994. So communities, when they felt ready, expressed that they want to engage in this, in the process of signing an integrated agreement. They will be funded for 12 months. That 12 months, they have to develop a needs assessment, assess the needs of their community, develop a community health plan based on local priorities, and then what used to be spent by the federal government at that community is what gets transferred with some administration dollars. But the services that the community is obligated to provide is basically based on a community health plan, which must include environmental health, immunization, communicable disease control, and if it's a larger community that has primary care delivered by nurses with an expanded scope of practice, that program has to be delivered. But what is included under the program is based on local priorities. Communities attach their budget to the community health plan, but they don't have budgetary line flexibility after that. If they want to shift how they allocate resources, they need permission. That's it. And then this contract gets basically rolled every 3 years or 5 years. Some communities are under 5-year agreements, others are under a 3-year agreement. The blue model has more flexibility in that it is pretty much like this one, with the exception that they have full budgetary line flexibility. And so they don't need to ask permission if they want to reallocate funding based on emerging priorities. The other difference is that surpluses are retained and can be reallocated to emerging priorities. Deficit must be assumed and remedied. So that's basically what it looks like in a nutshell, and this is what it looks like on a map. So if you look around, you will see that there is some green, but very little of it. In fact, 89% of communities have assumed some level of community control, and that means pink or blue. The most prevalent model is the blue model. That's the preferred one. The pink one exists. In some communities are not offered the opportunity of taking on the blue model because if they're below 500 members, we have communities of 20 members. That's not sustainable. They are staying green, and they're going to stay green unless they get amalgamate with other community and transfer as a consortium, if you want. The pink communities, if they come together, they can sign a blue model, but if they want to assume some level of community control at the community level, they will remain with the pink model. So that's how we manage sustainability issues. But it is really up to communities to decide we're going to transfer together or separate. We want to have the pink model. We want to do it in '94. We want to do it in 2004. No, we want to stay green because we have other priorities right now. And we don't want to basically take on this responsibility at this time. So what we have a system that delivers on outcomes, and we know that. This is a study that I led, and I'm very happy with the result. We didn't know that it would work, but we thought that it was time, given this fantastic experiment that we have. We've been talking about the value of community control or community engagement in primary health care since 1978, the Alma-Ata Declaration. It's been something that some of us have endorsed as being logical, that if you have community input, you're going to have more responsive services. But it's never been really evaluated for outcomes, not systematically. Even if you look in the international literature, there's very little. So we wanted to take that on, and I was at the time living in the province of Manitoba, where the Manitoba Centre for Health Policy is a renowned place for this kind of health services research. We have some of the best data in the world in terms of access policy and the ability to do those kinds of studies. So we want to look at indicators of performance of the primary healthcare sector, and we decide to look at avoidable hospitalization. Those are hospitalization for condition that, if the services are available, can be treated in a primary healthcare setting. So for example, if you live in community A and your rates of hospitalization for asthma is here, and you live in community B and your rate of hospitalization for asthma is here, chances are that unless there is incredible amount of pollution or something specific, but the communities are comparable, chances are that here, the program for asthma, the sufferers of asthma, may need to be beefed up a little bit. So investment in primary health care would reduce the rates of avoidable hospitalization for those conditions. There's a whole series of those conditions that are recognized as being responsive to primary health care intervention. We took the definition developed in the state of Victoria, and we adapted it to our population, so thank you for that. Continue to produce the good work, because we need it. And so looking at avoidable hospitalization, we were able to show that, in fact, yes, we do see that community control relates, that from the time a community signed an agreement for community control, actually they are able to reduce their rates of avoidable hospitalization. And it's mostly the blue model that's having an impact. We've not been able to demonstrate the same impact with the pink model. Part of it is that communities are smaller, so there's a sample size issue with that. So replicating the study in British Columbia, when I showed that to the Chiefs Task Force, so the First Nation chiefs in Manitoba, they said, yeah, but are you sure that we're being referred? It could be that we're not actually being able to refer people, so maybe we're not providing good care. And so I showed them the premature mortality rates. It's like, no, you're not killing your people by not referring them. It's actually getting better. And there was a lot of resistance among First Nation to this, because they say, no, it's getting worse. And I say, no, it's getting better. Your services are actually having an impact, and you're seeing more and more diabetic and people living with cancer because they're living longer with those conditions because they used to die sooner. And that is a situation that we're facing at home, is that we have more and more people living longer with chronic conditions, even in those communities. So it's very important to have a very robust primary health care service system at the community level, given the level of chronic conditions. So they were finally convinced. I've worked in the community control sector for 12 years before that, and I worked under that blue model. So I expected that from the point of time communities sign an agreement, that there would be a lag time. There would be maybe 3 years where we would see some sort of dips or some ups and downs. Some ups and downs in terms of adaptation. But in fact, that's not what we saw. What we saw is for the green model and pink model, we saw basically a flat line. Transfer is where we saw most of the differences, and it's from the day they sign an agreement. And I've asked myself, and this proposition needs to be tested, but what can be producing those kinds of results with this? And it's the community health plan. From the time the community sign an agreement, there's a plan in place. It's been based on community consultation and on a needs assessment. And there's broad consensus within the community about the direction the services will take and how they will be delivered. And there's broad-based support. I think that's what the communities are ready to roll by the time they sign an agreement. And that's why we're seeing those results. What we're still working on, appropriate funding. We live in a country that is somehow, and I don't mean to offend anybody, but comparable to Australia, in where there's a fair bit of racialization of incompetence. We have in the media discussion about community, anytime something happens in communities that it's Aboriginal problem, it always gets racialized at that cultural level. It's everybody. It's not just a problem in a community, it's First Nations. So it gets generalized. And there's this idea that investment in primary healthcare in First Nation may be bad money. It's money that is spent, but that won't deliver on outcomes. So that's why we're very happy to be able to deliver on a previous study that I just discussed. It is an environment that's vulnerable to cutback. We just had another 6% cutback of the First Nation and Inuit Health Branch of Health Canada. That means there'll be less money going back to community for service delivery. I'm showing a graph. In 1995-96, we needed to balance the budget in Canada. It's a good thing to balance budget, but look at where we were going in terms of expenditures. We've never recovered from those cutbacks, and still today it is very difficult to get Parliament to allocate appropriate funding to the system. And so we're struggling with that, and I know that this is something that I've had conversation here with APHCRI, and there are some similarities. We're still working on growing First Nation health expenditures. If you don't have a robust primary healthcare system, eventually you're going to have a growing rate of avoidable hospitalization because there's not enough services being offered. The services cannot keep up with needs, especially with growing chronicity. In the province of Manitoba, we've been able to demonstrate that, well, we've documented how much money is being spent by all levels of government on health services. So that includes hospitalization, service access, off reserve and on reserve. And it's growing. I did the study. I was part of the group that did the study in 2003 to 2004, and I've just repeated the study in 2009 and 10. In 03-04, we predicted, because we projected those costs to 2029, we predicted that it would be in 2029, 11% of the population, First Nation, would be utilizing about 27% of the healthcare budget. In fact, it's 32. It's growing fast, and it has to do with chronicity, and it has to do with reduced investment by the federal government in the community control sector in primary healthcare on reserve. And that is an issue, and we've not resolved that. We're still working on policy renewal towards comprehensive primary health care. We don't have a definition of what is essential primary health care services on reserve. In fact, the definition that I'm working on came from the territory, and it's a report by Tilton and Thomas. So I'm borrowing from Australia again because we don't have that piece of work done. It will need to be adapted to our context. There'll be less sunburn and more frostbites to be accommodated, but it's still, I mean, we can adapt those tools. So we're working on defining that and defining that national benchmark. We have to figure out new form of financial arrangements that are that include sustainability. We have to look at streamlining our reporting requirements, which is essentially the kind of issues that I'm hearing in Australia. So we're in a different context, different history, but we're coming to the same place in terms of problems and challenges. And we don't have a healthy Aboriginal health policy. We don't have a national framework like you have here. Healthcare and delivery on reserve is just a fragment of the overall healthcare system, and there is a risk when you shift, that only the on-reserve health services will be geared towards the needs of Aboriginal people, and that the rest of the system will say, well, they're off-reserve, they're in our system, and we run it the way we want. So responsiveness off-reserve and in hospitals is a problem, or can be a problem, and it needs to be addressed. And it needs to be addressed with guiding principles that would come from a national policy. We don't have that. We have jurisdictional confusion and fights between the federal government and provincial government as to who should pay for what. And we've not resolved that either. We've named them, and I named them in publications, but they're still fighting over who should pay the bill. We have regionalization. There's regional health board in every province except for Alberta, but we don't have a way of integrating a regional health board that are provincial with the First Nation healthcare system, which is federally funded. Those operate separately, and that can create gaps in services and have some dire consequences. And so we need a policy framework that respect the rights to self-government, that respect jurisdictional issues, and that gives guiding principle to all authorities involved in healthcare delivery so that we can close the gap. And we're not there yet, and we're far from that. So my last slide. we start from a very different place. And our history is much more sort of settled. We have a legal framework that does not exist here. And we have a community control sector that is rolled out nationally, which you don't have here. But we have some issues that are sorted out. We know that community control works. We have chief and council. We have all kinds of things that are actually working fairly well. But some of the challenges are common to both countries. And this is why I've been coming back and forth, because I've been borrowing from your work, so thank you, and please don't stop, because it's very, very helpful. And I'm also been sharing some of the work that we've been conducting in Canada that can inform some of your discussions. So thank you for the opportunity to be here and address you this afternoon, and I'm now ready to take a question if you want.
Thank you for that. That was very interesting, and it's always lovely to hear the Canadian context as opposed to the Australian story as well. But just in terms of workforce and the Indigenous participation in the workforce, we have a number of Aboriginal and Torres Strait Islander doctors through graduating, nurses, you spoke about nurse practitioners as well. So we have people organisations around nurses, doctors, Aboriginal health workers. If you'd like to comment on what that looks like in Canada, and how has that contributed to the health of the First Nations people in Canada?
It's very much the same thing. In fact, the organization that you're talking about here in Australia talked to us. So those are networked internationally as well. And there's that sort of sharing of experience and stories across. And research project also are being carried across between the three countries, Canada, Australia, New Zealand, around issues of Indigenous workforce, health workforce. Increasingly, because this is a nurse-centric system, well, first of all, under transfer, generally, the communities that I've worked with and the model that I'm familiar with is what communities will put in place is a health director that is from the community. Then there will be, and I don't mean a hierarchy because usually people work in a very flattened hierarchy in those communities, but I will put it in layers just for the sake of discussion. Then the nurses, and the nurse may be actually 6 months to 2 years in community. Many are not from the community, some are from that community, some are Indigenous but coming from other communities, so that varies. The number of Indigenous nurses is growing. It's growing quickly, but not quickly enough to feel the demands across the country. And then there's a whole group of Indigenous health workers that may be having a bachelor in psychology, maybe working as the Aboriginal health worker, maybe working as the addiction workers, there's elder health workers, there's all kinds of positions that were created under community control that are paramedical roles, that are trained on the job, that are doing the health promotion, prevention, assisting nurses, and this becomes sort of the backbone of the healthcare team as professionals rotate through the community. So continuity of care is not invested in transient workers. It's actually invested in workers that remain with the community and with the health director of the health coming from the community. So that's the model that exists in many of the communities that I've worked with, especially in the larger communities in the north. So I can't give you numbers as to the number of Aboriginal nurses and the number of Aboriginal doctors, but that is obviously growing. We've invested in schools in terms of a Northern Medical School. UNBC has a Northern Medical School. We have a Northern Nursing School, and we're trying to recruit from those communities in order to fill that needs. But also training our nurses and our doctors that are non-Indigenous into understanding that context as well. Does that address the question?
Going back some slides ago, and you were talking about the 60% and the 3 to 5 year contracts. How does that actually roll out on the ground? So at the end of that 3 or 5 years, what happens?
Oh, it gets renewed automatically. This is not a competitive environment. There will be no way you could tender this community to the highest bid or the lowest bidder and have another authority moving in. There is no tendering process in that context. It's a single funder with a single provider. And the 60% sorry, the 60%, sorry, I didn't touch on that. Communities, there's a number of other programs that the federal government rolls out for those communities that may be a new program that is very complex, like home and community care was being, when it got rolled out in 2001, was rolled out outside of that flexible contract. So it could be rolled out in a standardized way with tools, with training, with support. So capacity and change management were funded. And also with clear parameters on how it could be rolled out so it could be evaluated in a standard way. Once it got evaluated, then it became, and it was working, then it got transferred and got integrated into the relational contract so communities can then make their fine-tuning to make it fit better their context. The reason why it was left outside is so that it can be evaluated to prove to Treasury Board and Finance that it actually works. So it takes a long time to roll things that way. At the same time, it's very systematic, and we are working in a very in a controversial environment. We're working in an environment where it's again debated whether this is good money or bad money. So prudence has to prevail, and that's a prudent way of rolling out a program. Does that address? And so there are a number of those initiatives that get rolled out that way. I'll go at the back and then I'll go here. So, at the back. Yeah.
Thank you.
You were faster.
Sorry. You said that the community health plan was a point of difference, and I guess I had a couple of questions around that.
Yeah.
One, how did it happen? Do people from outside the community come in and work with the health centre to develop the plan, or is it something that happens internally? And I guess a related one, is there an evolution between those three models that are placed up there? In the sense of the people move from the classical contract to the first integrating them to the transfer? And
this is,
if you could already explain that.
No, not at all. This is the default category. So yes, there's a natural evolution. Usually it is to either here or here, right? And with some communities transiting from here, but there's many communities that are now stuck in that model because they're too small to transfer under the blue model. So they may not, that link may not happen, but some have progressed from here to here as well. And your first question was the community health plan. How did that work?
How does it actually happen? What process do people use?
For the very first one that was created, usually communities hired facilitators or consultants. So I've been involved with some of them in terms of facilitating the process and assisting in creating this first tool. And then it gets refreshed and renewed every 5 years. The process is, there are templates, and you can find them on the federal website of the community health plan. And so it is a template, it is a scripted process, but it is also flexible. Yeah, okay, if I answer, sorry, I'll stop there. Yeah, okay, in the interest, and then you.
Thank you for the talk. It was really good. I actually spent the last 6 years working for First Nations Indian Health Branch in Ottawa.
Oh, yeah?
Until last year. So it was good to listen to all of this. Mine's
Okay.
I have 3 questions. You talked about the need in Canada for a national health policy framework, how that would be ideal. And I just know from my personal experience that the federal government, when negotiating with chiefs and council and Aboriginal leaderships in each province, not all the provinces are at the same level to deal with their health issues. And so I know in British Columbia they're moving towards a First Nations Health Authority because the entire Aboriginal leadership in the province, with the province of BC and the federal government, are willing to come together. I know Saskatchewan, they've signed an MOU. They're not. But
they're dancing together right now, yeah.
Manitoba wouldn't even be possible at this point.
It's being discussed by the Assembly of Manitoba Chief right now.
It's a lot more difficult.
And it's going to take a while.
Yeah. It's difficult to have something national in Canada. So with that in mind, how would you see the federal government taking a leadership role? Is it even really possible in the Canadian context for there to be a national health policy? So, sorry, that's question 1. But then 2 sub-questions. Your research in BC.
Yeah.
I know that there's an interim First Nations Health Authority. Have you seen a further drop in the gap between health status? And do you think a type of Aboriginal health authority here in Australia would be a good idea for at each state level.
Okay, so the national policy framework, and then whether we're seeing outcome changes by something that was rolled out last year, no. But I'll come back to that in a minute. So a national policy framework, there are certain things that we know that need to happen. And well, first of all, we don't have an Aboriginal group. We don't have just First Nation. We have Inuit, we have Métis, we have non-status people that don't fall under, they are Indigenous, but they don't fall under the Indian Act. And groups have claimed differences, and there's no way we can have a pan-Aboriginal policy in Canada. That's never going to fly because of those differences. So there's a recent court case ruling in January that actually says all these people are actually Indigenous and they should be under federal jurisdiction. We'll see when the dust settles what that looks like in policy, and there will be most likely an appeal from the federal government on that one anyway. So yeah, it contested territory with many voices and many high-stake debates. But there are certain things that we know that there is broad consensus over what should be in a national policy. The Jordan principle, for example. Jordan was a young Cree boy that was born with a syndrome that we knew was terminal, and we knew that he probably had 3 years of life. He was in a hospital under very intensive care, but when he was ready to be discharged at year 2, so that it could be in a special care home, but in a family setting that would have been trained to look after him, so it could be not just in a hospital, but have the last year of his life in a family setting. Nobody could agree as to who should pay, so he stayed in the hospital and died there. That became well known, and then governments have agreed to the Jordan principle, which is provide the service first and fight about the bill later. And so that can be entrenched in a policy, and there will be broad support for that. We know that we need to have some level of self-determination, self-government at all levels. There has to be representation of Indigenous people within the healthcare system that is not under Indigenous control. There has to be dialogue and coordination. We know that any policy that falls from a national framework will require consultations. Those are broad and high-level principles that can be embedded into a framework, and they become sort of principles that the provinces and the territories and the federal government can then all basically hang their hat on and say we're setting up processes that live up to those principles that we've all agreed on. So it's not going to be an implementation policy, it's going to be a high-level policy. And you know, we have the Canada Health Act. I'm getting into Canadian talk for a minute. Please forgive me when I'm talking to my fellow Canadian. The Canada Health Act is a federal act of parliament that basically implements Medicare, which is a provincial jurisdiction. We've been able to do it once, we can do it again. So we have history of being able to cross jurisdiction with high-level, principle-based sort of policies, and we can do it again. As for the First Nation Health Authority, you're quite right. We are moving into different level of self-government. For example, we have in British Columbia, this is a province where no treaties were signed because the province says we don't sign treaties. These people in 1904, when the province was formed, basically BC said they won't exist anymore. You know, in the future, smoothing the dying pillow was the principle, I guess, at the time, was a thought at the time. Didn't happen. And so now we're signing treaties because the Supreme Court of Canada said to BC, you need to sign treaties. You've been encroaching on those territory and you're in violation of the Royal Proclamation of 1763. I told you that's an important document. BC just realized that not too long ago. And so now there's a new order of government for health that is being negotiated, where the equivalent of OATSI, the FINIB office for that region that controls all the funding that goes to those communities, the talk is to transfer that to a First Nation Health Authority. I think the agreement was signed about a year ago. I'm in communication with the First Nation Health Authority on 3 research projects. So I'm watching that very carefully in terms of how it unfolds. But it is a black box transfer. It's basically taking FINED and calling in the First Nation Health Authority. I mean, it will be an indigenized, under indigenous control, but in terms of the resources being transferred, it's a black box. So it's not going to be appropriate funding for reserve. It's going to be existing funding for reserve health services. The idea that that can produce outcomes now, we're not going to see, the system is not changing, or may change, but it will take some time for change to be enacted. We just received today news that we got funded to have a policy forum with the First Nation health authorities. I was on that proposal, so I would be able to answer this question much better in 6 months. But we'll be sitting down to say, okay, what will that look like? What are the decisions that you're making? What are some of the innovation that you can actually consider within the context of this sort of black box transfer? So we'll see. The dust hasn't settled on exactly what that will look like. Did I answer all 3 questions? Or is there one outside?
I can ask you the third round.
Okay. Okay, and you've been very patient.
Okay. First of all, Professor Lavoie, thank you very much for the presentation. My colleagues and I are from Awatsi, so we're very interested. I think in terms of demonstrating the impact of transfers to community on avoidable hospitalizations in Manitoba, I think that's got to be a world first. And I think I heard you say you're going to try and replicate it in BC.
We are replicating in BC, so that's another one we're working on with the First Nation Health Authority. They're really keen on seeing which community, one of the key questions here is to say, okay, so community, a model of community control has produced better outcome, but which community has produced better outcome? And then to go into those communities and say, what are you doing right?
Right.
So it's learning from strength rather than deficit kind of documentation. And go ahead, sorry.
And then I have a question.
Yeah.
Because in Australia, our model tends to be GP-centred. I mean, we are Aboriginal health worker-centred, but in practical terms, it's GP-centred. And so I'm just curious, do some of the larger reserves attract a GP to their clinic who then builds the province?
Yeah, well, that does happen. It's complicated because you need to have co-funding in those circumstances where, I mean, you can imagine the GP is fee-for-service for the most part in Canada, yeah, just like it is there. And so if you're traveling to a reserve, you're not seeing patients every 10 to 12 minutes. So there is a loss of income. So that usually, there's a federal payment for that time, that loss of time. And that's pretty hard to secure these days because the federal government does not want to pay for GPs because that's a provincial jurisdiction. So that's one of those situations. Individually, communities that are close to a point of care that is provincial or where there is general practitioners have been able to come into some agreements in some cases. There are some universities like University of Manitoba and University of Saskatchewan that have had a history of having linkages with certain community to provide doctors. So there are those kinds of arrangements, but it's sporadic, it's different in different places, and staffing those kinds of models is difficult. Maybe while finding doctors, I'm having the same difficulties. I don't know, maybe it's different here. But for us, communities that are remote have problem finding doctors willing to go there.
So if people travel off reserve for GPs, for specialists, is there good communication back to the team on the reserve, the health team?
Yeah. What you cannot see in this map is actually there are 4 different kinds of facilities. There's nursing stations. Those are the ones with primary care. And the community have to be a certain size and a certain distance from a provincial point of care. So it's actually over 60 kilometers, and community has to be big enough to have a primary care designation and get that kind of funding. Otherwise, it's basically public health, primary, secondary prevention is basically the level of care in most communities. And where there is a nurse practitioner or where there is a nurse with an expanded scope of practice, generally the communications are fairly good and there's a referral back and forth. where there isn't, because it's mostly primary, secondary prevention, the follow-up. In some communities, it depends on the perception of the GPs and their willingness to write the letters. We will have problems in terms of communication when we have elders going to see a gynecologist and coming back and being really upset because they don't know what happened, they don't know what they were told, and there's no way to get to know what the problem was. So misunderstanding and so on, that continues, and those stories abound. They abound here, I'm sure, and they abound in our country as well. So we've not quite sorted that out. The nursing stations tend to be in a better position in terms of continuity of care across those jurisdictional boundaries. Is that?
Yep, thank you.